Hello and good evening, everyone. Welcome to our 86th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Henok, a general physician and first aid trainer from Blue Hills, Ethiopia. Today, it's a pleasure having Mr. Henok Ababu here with us to give us a presentation on the evaluation and management of delirium. Mr. Henok Ababu, is a mental health professional specialist and a lecturer and researcher at Delirium University. So, Mr. Henok, the stage is all yours.
Okay, thank you very much. Hello, everyone. Welcome to this webinar on evaluation and management of delirium. My name is Henok, and I'll be your guide throughout this session. So, in our today's session, we'll discuss about evaluation and management of delirium. So, specifically, we'll discuss about what delirium is, what are the causes and risk factors of delirium, how can we identify and diagnose delirium, and also we'll try to see the effective strategies to manage delirium and prevention measures. Okay, so we'll have time for question and answer as the moderator already explained. So please don't hesitate to submit your questions throughout the session. You can use the chat box for that. I hope you'll find this webinar informative and helpful. So let's get started. First of all, I'll give you an introduction on why medical conditions, I mean mental illnesses, are common in medical conditions, and what are the common manifestations or symptoms of mental illness among the medically ill population, and then we'll go directly to our today's topic. So, as an introduction, the co-occurrence of mental health issues in medical illness is a norm rather than being an exception. So, there are many consultation cases coming from a lot of wards, like that of the medical ward, surgical ward, emergency ward, right? The OB-GYN ward. So, one of the common reasons for consultation is the manifestation of psychiatric symptoms by a patient who is admitted being for an otherwise medical case, right? So these mental health issues are mostly prevalent in this kind of population, but still it is ignored by the sufferer as well as it is deprioritized by the treating physicians. Okay, so these mental health comorbidities are crucial because they can affect the outcome of the medical condition by itself, and they can impact the person's overall functioning. So the coexisting mental illness adds to the patient's suffering, not only by its own, as I said, but it can also worsen the outcome of the primary medical illness. Okay. So one thing we should understand here, which is also my opinion, is that it is important to understand the dichotomous view of medical and mental is incorrect, and it often adds to the primary source of confusion because from experience, let me tell you my own experience. So patients who are visiting a certain medical center or hospital go through a triage, right? So if a patient with medical condition or with mental illness says just one symptom, so they will directly send you to either the medical OPD or the psychiatric OPD, okay, without checking what it is, right? So my view is that mental illnesses are also medical conditions, okay, like any other medical conditions. Mental illnesses also occur due to change in the physiology, structure, and function of the central nervous system in the brain. Okay, so despite there are additional environmental and psychosocial factors. Okay, so current modern researches also show that the psychiatric conditions have a biological causes, right? So in older textbooks of psychiatry, you will find that the etiology or the causes of psychiatric conditions are unknown, or they are usually emphasize the psychosocial factors. But recent and modern research findings shows that there are biologic bases for psychiatric conditions. Okay, it could be genetic, it could be molecular, it could be receptor associated. Okay, it could be due to hormonal abnormalities, right? So there are biological bases for psychiatric conditions. So the same is true for physical illnesses. Physical illnesses that results from this genetic, molecular, or biologic base are therefore expected to have associated mental symptoms. So, okay. So, additionally, medical illnesses, surgical operations, and treatments, and also can alter the delicate chemical balance of the brain. Okay. So there is no single mechanism that explains why psychiatric conditions occur in patients with medical conditions. Okay. Instead, such presentations involve a complex of interplay of factors. Okay, such as the first one could be the physical effect of the illness itself. It could be stress of coping with a chronic condition. It could be the side effect of medication. Okay, so I'll try to elaborate each point here. So, when we say the physical effect of the illness itself, for example, medical conditions like a tumor or a defect in different parts of the brain can lead to manifestation of a psychiatric condition. Let it be depression or psychotic symptoms. Okay, electrolyte imbalances or metabolic changes such as hyperglycemia can present as confusional symptoms, right? uh, and also disorders of the thyroid gland, for example, the hyperthyroidism or hypothyroidism can present with manifestation of psychiatric symptoms. Okay, with depressive symptoms or with bipolar one manic symptoms. The second one is stress of coping with a chronic condition by itself may predispose this group of population. Okay, so the emotional burden or the psychological strain associated with these medical conditions can lead the patients to have a mental conditions, right? The loss of control or uncertainty about the future also contributes to the development of mental illness in this group. Okay, and the social isolation related with medical conditions can contribute to the development of mental illness in this group. The third one is the side effect of the medications used for treating the medical conditions. Okay, so the list of such drug-mind interaction is essentially never-ending. Okay, so for example, I have put here some examples. Some ART medications can cause side effects that mimic or worsen symptoms of psychiatric disorders, especially from the group of ART medications, the so-called the protease inhibitors. Okay, they are usually associated with causing or worsening symptoms of psychiatric disorders in patients who are taking ART medications. Okay. Uh, in vulnerable patients, even commonly used antibiotic medications like ciprofloxacin can result in symptoms of delirium. The commonly used steroid medications can also cause psychiatric symptoms in some group of patients. The drugs we use for the treatment of epilepsy, while they are crucial for managing epilepsy, they can sometimes cause cognitive decline, diabetes mellitus or arthritis, for example, leprosy, or being diagnosed with HIV/AIDS, or those requiring advanced medical care like dialysis in kidney failure or chemotherapy. These conditions are associated with higher rates of mental morbidity. Okay. Therefore, management of mental health issues in medically ill patients require special considerations. It requires skills and an integrated management approach, uh, combining the expertise of multiple branches of medicine. A final important consideration that I would like to raise here is individuals with established mental illnesses have a risk of developing medical comorbidities. So those patients with a known psychiatric condition, whether they are admitted to a psychiatric ward or whether they are following an outpatient treatment, they usually have a medical condition, a medical comorbidity, which is usually skipped or which is usually unprioritized. Okay. Let me give you an example. A research done in New York in 2020. So it was done among psychiatric patients. So the title of the research is Medical Comorbid Diagnosis Among Psychiatric Inpatients. Okay. So it was done in New York in 2020. And surprisingly, it showed that approximately 75% of those psychiatric inpatients had at least one medical comorbidity. So that's a very huge figure. Okay. So, and higher rates was seen among older age patients, among female gender, and non-schizophrenia diagnosis. Okay. So, what I want to emphasize here is psychiatric conditions not only occur in patients with medical illness, but the vice versa is also true. Medical conditions are prevalent among patients with psychiatric conditions. Okay, so obesity, diabetes, cardiovascular diseases, and substance use disorders are far more common in this group as compared to the general population. Okay, it could be due to the lifestyle they use. It could be due to the psychiatric medications that they are exposed to. Okay, there are a lot of factors for that. Most psychiatric patients have decreased physical activity. Okay, as compared to the general population. So these all factors contribute to the the, the, the risk of psychiatric patients to have a certain medical condition. So saying that, I will directly go to our today's topic, which is delirium. Okay, so the word delirium is originated from a Latin word delirium, which means to deviate or to be deranged. So the Amharic dictionary, so the meaning in Amharic dictionary says kajet or yenedad mabed. So these terms shows the common symptoms that are seen in delirium: the confusion, yeah, the disorientation, and the term nedad usually shows medical conditions with associated with fever, right? So the, this is the terminology associated with delirium. So it is a most common psychiatric condition in patients with medical illness, particularly among those who are older, especially age of 65 and above, are having a high risk of delirium. Okay. And this delirium is associated with many complex underlying medical conditions that we will discuss later. And it's usually missed by physicians due to its subtle presentation, especially the hypoactive type of delirium that we'll discuss later. So according to the American Psychiatric Association and on DSM-5 text revised, there are 5 key features that characterize delirium. Okay, so the first one is a disturbance in attention and awareness. So this is a required symptom, and it involves easy distraction, inability to maintain attentional focus, and a varying level of alertness. That is the first key feature. The second one is the onset should be acute. Okay, the onset should be acute, which means the presentation of the symptoms is from hours to days. Okay, it represents a change from a baseline mental status. Okay, and often fluctuates throughout the day. It has a fluctuating course throughout the day. And the third key feature is there should be at least one additional cognitive disturbance. Okay, either it could be a disturbance in memory, a disturbance in orientation, a disturbance in language, visual spatial ability, or perception. Okay, there should be at least one additional cognitive disturbance. And the fourth key feature is the disturbances that are listed in criteria A and C should not be secondary to another neurocognitive disorder. That is, it should not be secondary to, for example, a major neurocognitive disorder, which is previously called dementia. Okay, it should not be due to other amnestic disorders. Okay, and the last one is there should be evidence that shows that the disturbances are a direct physiologic consequences of of another medical condition. Okay, an underlying medical condition. It could be a medical condition, it could be substance intoxication or withdrawal. Okay, or it could be a combination of these causes. Okay, so this is the key features that characterize delirium on DSM-5. Okay, so there are additional features of delirium, that is psychomotor behavioral disturbances such as hypoactivity, hyperactivity with increased sympathetic activity, and impairment in sleep duration and architecture. Okay, and there are variable emotional disturbances including fear, depression, euphoria, or perplexity. Okay, there can be psychomotor disturbances like agitation, and there can be tremor or perceptual disturbances like hallucinations. So these are additional features. They are not essential features, but they can add up to the essential features for the diagnosis of delirium. So when we see the epidemiology of delirium, uh, so there are certain papers that I tried to review. So a meta-analysis done in 2020 of 33 studies in medical inpatients showed overall delirium prevalence of 23%. Okay, 23%. The risk of delirium is high among patients who undergo major surgery, especially under emergency conditions. So under these conditions, the risk of delirium can raise more than 20%. Okay, and another systematic review done in 2019. Okay, in patients undergoing coronary artery bypass grafting, delirium prevalence was 24%. Okay, so as you can see, the ranges are still high. Okay. There is also a local study done in our country, Ethiopia, which uses the delirium screening tool, the confusional assessment method, which I will discuss later. Okay. And this study showed the prevalence of delirium to be 27.6%. There is also one study we conducted in Jimma Medical Center. So the principal investigator is my wife, Betalim. and it was her thesis for master's graduation. So she did the research, the prevalence of delirium in emergency setting. Okay, so and in that study we found a prevalence of 26.6%. Okay, still high figure. So when you see the ranges of the prevalences, you can tell that delirium is a common condition in medical settings and in emergency settings. So mortality related to delirium can be as high as rates among patients with acute myocardial infarction or sepsis. Okay, so this delirium has a high mortality risk, so as high as in patients with myocardial infarction or sepsis. So typically it ranges between 22 to 76% in hospitalized patients, especially in hospitalized patients. So in Kaplan 2017 edition, you can see this 1 year mortality rate associated with cases of delirium to be 35 to 40%. When you see the pathogenesis of delirium, so it is poorly understood because there is no single mechanism that universally operates, or you cannot tell that there is a single cause for delirium. There are a lots of causes or a combination of causes for delirium. So most theories that try to explain the pathogenesis of delirium are overly simplified. For example, some theory suggests that the disturbances in brain oxygen supply versus demand kind of theories. Okay, so the best understood theories are the concepts related with neurotransmitter mechanisms. Okay, specifically acetylcholine, dopamine, serotonin, glutamate, and GABA. So when you see the role of acetylcholine in the pathogenesis of delirium, so usually a decreased level in the acetylcholine is associated with the symptoms of delirium. So the evidences that support this theory are: the first one is uh, anticholinergic drugs, for example, like that of benztropine. When they are given to healthy volunteers, they can cause symptoms of delirium, especially in older adults. Okay. The second one is cholinergic agents like that of physiostigmine. They reverse delirium associated with anticholinergic drugs. Okay. The third one is medical conditions that precipitate delirium, such as hypoxia, hypoglycemia, and thiamine deficiency. These conditions are known to decrease acetylcholine synthesis in the central nervous system. And the last one is Alzheimer's disease, which is characterized by a loss of cholinergic neurons, increase the risk of delirium due to anticholinergic medications. So the second neurotransmitter involved in delirium is dopamine. So dopaminergic excess is appear to contribute to the development of delirium, possibly owing to its regulatory influence on the release of acetylcholine. Okay, so one suggested mechanism is the involvement of dopamine in maintaining and shifting attention. So when this role of dopamine is disturbed, patients with delirium can develop disturbance in maintaining and shifting their attention. Okay, so the other evidence that supports the role of dopamine in delirium is dopaminergic drugs. For example, drugs that are given for the treatment of Parkinson's disease, like that of levodopa. Okay, and antidepressant medication that decrease the reuptake of dopamine, like that of bupropion. Okay, these are recognized precipitants of delirium. And the other one is dopamine antagonist medications, like that of antipsychotic agents, effectively treat delirium symptoms. So these findings support the theory that that says that dopamine is involved in delirium. Other neurotransmitters that are involved in the pathogenesis of delirium are serotonin and glutamate. So both high and low levels of serotonin are associated with linked to delirium, especially high level of serotonin is associated with delirium, and the other one is glutamate, which is a main excitatory neurotransmitter. So overactivity of this glutamate system may play a role in delirium by disrupting the normal brain function. So still, these are theories. The exact role of each neurotransmitter in delirium is still being investigated. Okay, so when we see the risk factors of delirium, as I said earlier, delirium is a multifactorial disorder. So the etiologies or the factors, not etiologies actually, the risk factors that contribute to delirium are multifactorial. Okay, so we can divide these factors into two groups. The first one is factors that increase baseline vulnerability. We call them predisposing factors. And the second group are factors that precipitate the disturbance or precipitating factors. Okay. So when we see the predisposing factors or factors that increase baseline vulnerability, the first one is demographics. As I said earlier, older age, especially age greater than 65, is associated with high risk of delirium and male sex. And cognitive status of the individual, okay? Having a diagnosis of major neurocognitive disorder according to DSM-5 or dementia, having history of cognitive impairment and having a previous history of delirium can put patients at risk of delirium. Okay, those patients with sensory impairment, whether it is hearing impairment or visual impairment, can be a predisposing factor for delirium. The other one is decreased oral intake. Okay, dehydration, malnutrition can lead patients to develop delirium. Okay, and exposure to drugs. Okay, psychotropic drugs, especially antipsychotic drugs, psychotropic drug exposure, drugs with anticholinergic properties, not antipsychotics, anticholinergic properties, and alcohol abuse. Okay, especially delirium can happen in alcohol withdrawal. As you know, there is alcohol withdrawal delirium to the level of delirium tremens. Okay, and coexisting medical conditions like chronic renal or hepatic diseases, stroke, neurological diseases, metabolic abnormalities, infection with HIV virus, fractures or trauma, and terminal diseases like cancer or any other conditions can be predisposing factors, or they can increase the baseline vulnerability of patients to develop delirium. So the second group of factors are factors that precipitate the disturbance. Okay, so precipitating factors by definition are factors that are near to the onset of the certain condition. Okay, so drugs, exposure to drugs, whether it is sedative hypnotics, narcotics, anticholinergic drugs, okay, a combination of drugs or polypharmacy, alcohol or drug withdrawal can precipitate delirium. Okay, primarily neurology conditions, intercurrent illnesses, okay, infections, fever or hypothermia, dehydration, poor nutritional status, surgery, any kind of surgery, especially this the so-called the big surgeries, okay, cardiac surgery or prolonged cardiopulmonary bypass, okay. These surgical procedures can put patients at higher risk of delirium, and environmental factors, okay. For example, being admitted to the ICU, use of physical restraints, use of bladder catheter, okay. For example, the use of bladder catheter was one of the factors associated with delirium in our study, okay. Use of multiple procedures, pain, especially unmanaged pain, okay. Emotional stress and prolonged sleep deprivation are the factors that precipitate the disturbance or delirium. Okay, so when we see the signs and symptoms of delirium, delirium exists across a range of arousal levels, either as a state between normal wakefulness or alertness and a coma. We will see the subtypes of delirium, the three subtypes of delirium, the hyperactive one, the hypoactive one, and the mixed one, okay? I'll come to that on the coming slides. So I will directly go to the signs and symptoms. The first one is inattention, okay? There is a disturbance in attention that is required for delirium diagnosis. This can present as an impaired ability to direct, to focus, or to sustain and to shift our attention. So patients with delirium have impaired ability to direct, to focus, to sustain, or to shift attention. The second one is memory impairment. Okay, so there is a memory impairment in delirium. That is an inability to encode new information. We call that anterograde amnesia. Okay, so they have difficulty of establishing new memory. So by this we mean that the memories that are created before the onset of the delirium are usually preserved, okay. But the problem here is that they have difficulty of building up new memories, okay. uh, and usually they can also have difficulty of recalling the informations that are built even before the onset of the delirium, okay. That is the memory impairment that can happen in delirium. The third one is disorientation. So the patients with delirium might be disoriented to self, disoriented to place, okay, or to time. Additionally, they can be disoriented to a situation and not recognize the environment or appreciate what's going on around them, okay. The other one is disorganized thinking. So disorganized thinking is usually noticed with speech that makes limited sense, with apparent irrelevancies, and it can involve poverty of speech, loosening of association, preservation, tangentiality, or other signs of thought form disorders. Okay. And the other one is sleep-wake disturbances. So sleep-wake disturbances are common in patients with delirium. So it can happen as fragmented sleep pattern or even sleep-wake cycle reversal. Okay, patients with delirium might be drowsy or sleepy at the daytime, and they can be active at the nighttime. Okay, so sleep-wake disturbances can happen in patients with delirium. Uh, they have also psychotic experiences, okay, usually related to persecutory themes of impending danger or threat in the environment. For example, they can say that a medication given to them can be a poison. Someone is trying to poison them, okay. They can have this kind of persecutory thoughts. They can also have perceptual disturbances, okay, usually illusions and hallucinations, okay. So by illusion, we mean that there is a misinterpretation of external stimuli. For example, they can misinterpret the IV line on their hand as being a snake on them, okay, or they can have perceptual disturbance of hallucination, okay. They can have auditory hallucination, visual hallucination, or any kind of hallucination can happen in patients with delirium. The other one is mood lability. Okay, there is distortion to perceived or communicated emotional state as well as fluctuating emotional states. So there can be rapid changes between terror, sadness, and joking. Okay, they can be laughing at one time and then they can be crying the next. So they have a labile mood. There is also motor activity changes, as I said earlier. Based on the psychomotor subtypes, delirium is classified into three. So hypoactive delirium, hyperactive delirium, and mixed type of delirium. So when we say hyperactive, there are symptoms of hyperactivity, okay, like hypervigilance, restlessness, fast or loud speech, irritability, combativeness, okay. These symptoms can happen in the hyperactive type, whereas the hypoactive type is manifested by decreased alertness, okay, drowsiness, lethargy, slowed movements, okay, staring at one place, and apathy, okay. And the third subtype is mixed level of activity. So the mixed type is usually a fluctuation between the hyperactive symptoms and the hypoactive symptoms. So studies show that from these three subtypes of delirium, the hypoactive type of delirium is most common. Okay, that's why delirium is usually missed in medical settings. Okay, and the hypoactive type is followed by the mixed type and then the hyperactive type. Okay, so that is the order of their prevalence. So we're coming to an important point now. So the evaluation of delirium. So there are two important aspects to the diagnostic evaluation of delirium. The first one is recognizing or detecting the disorder. And the second one is uncovering the underlying medical causes. Okay. So when we say recognizing the disorder, clinicians often fail to recognize delirium. In some reports, this can happen in more than 70% of the cases. Okay, so behavioral problems or cognitive impairments wrongly attributed to the patient's age, to neurocognitive disorders like that of dementia, or to other mental disorders. So it's usually overlooked, and clinicians are not usually alert to such symptom presentations. So the second one is investigating medical etiologies. So we need to investigate underlying medical etiologies in the evaluation of delirium. So it could be fluid and electrolyte disturbances, because as we said, these electrolyte disturbances can be an etiology for delirium. Okay, so we can send different investigations to check out this one. Okay, electrolyte level checking may be needed to check this one. The second one is infections. Okay, your urinary tract infections, respiratory tract infections, or other kind of infections can lead patients to develop symptoms of delirium. The other one is drug or alcohol toxicity. Okay, so whenever we evaluate patients for delirium, we need to check for any medications they are taking. Okay, whether it is over-the-counter drugs, the commonly used anti-pain drugs, or any kind of drugs that patients might be taking. Not only the patients, any family member who is taking a medication should be checked. Okay, so we need to check if the patient is taking any medication or any other family member is taking a medication, because the patient might accidentally take those medications taken by a relative. Okay, The other one is withdrawal from alcohol, which is the common one, because alcohol withdrawal can lead to symptoms of delirium. Okay, withdrawal from barbiturates and benzodiazepines also, because the mechanism of action with alcohol is almost the same with these drugs. So the withdrawal from these drugs can lead patients to symptoms of delirium. Okay, the other one is metabolic disorders like that of hypoglycemia, hypercalcemia, uremia, okay, liver failure, thyrotoxicosis. This all should be investigated because we need to know the underlying causes for the delirium, okay. And this is not an exhaustive list. There can be a lot of factors for that can contribute as a medical etiology for the delirium. So clinical confirmation is always mandatory. A change in the level of consciousness is often the first observable clue. Okay, so clinicians must not normalize lethargy or somnolence by assuming that illness, sleep loss, fatigue, or anxiety are causing the changes. So a commonly made mistake by clinicians is that whenever a patient gets lethargic or somnolent, okay, or dizzy, we tend to normalize that because okay, he's having a medical condition that can cause him or her to be lethargic, or the patient might not get adequate sleep. Okay, so by giving these reasons, we tend to normalize these symptoms, which is the main reason that it is usually missed in the medical setups. Okay, so in order to tackle that, conversation with the patient is key. So we have to communicate the patient. Okay, so whenever we communicate with such patients, one thing we should not miss is that superficially appropriate conversation should not persuade you that the patient is okay. Okay, for example, uh, giving short answers only for your questions. Uh, so difficulty in explaining the symptoms he or she is having. Okay, so this can give you an alert sign, okay, for these symptoms of delirium. So whenever you are in doubt of whether the patient is having a delirium or not, you can conduct a formal mental status examination if you are a psychiatric professional, or you can consult. Okay, so a formal mental status examination should be performed, and if there are findings, especially in the sensory and cognition component, you can further do the mini mental status examination. Okay, so the mini mental status examination, uh, let me tell you some points about this mini mental status examination. Okay, it has an 11 item. Okay, it only takes 5 to 10 minutes to fill, and it is practical. It has 5 areas of cognitive functions. Okay, orientation is the first one. The second one is registration. The third one is attention and calculation. The fourth one is recall, and the last one is language. So maximum score of this mini mental status examination is 30. Okay, so each components have their own score. For example, the first one, orientation, have a score out of 10. The third the second one, registration, has a score out of 3. The third one has a score out of 5. The fourth one has a score out of 3, and the last one has a score out of 9. So by summing up this, so if a patient scores a score below or equals to 23 is an indicative of cognitive impairment. Okay, so you can do mini mental status examination, and you can screen patients for delirium by using this mini mental state examination. There are also other clinical tools like the the confusional assessment method that I will discuss later. You can also use simple tests like serial sevens. Okay, you can tell patients to subtract 7 from 100. Okay, so you can check the attention and the concentration of the patient by this, or you can instruct the patient to spell the words such as farm or world backward and forward. Okay, so these are simple tests of attention. You can do that. So the other important point in the evaluation of delirium is history taking. So usually you take history from the relatives, because it is difficult to take history in confused or uncooperative patient. Okay, usually patients with delirium are uncooperative to give you a history, so you obtain it from relatives. Okay, so you have to ask if the patient is having recent febrile illness, if there is history of organ failure, if there is history of alcoholism, okay, or if there is any drug or substance or medication that the patient is taking. Okay, you have to check all these parameters while you take history. Okay, and next to history taking, there should be a general physical examination. Okay, physical examination. Of course, it's difficult to take in uncooperative patient, but the clinician should focus on upon the vital signs of the patients, a state of hydration, skin condition. Okay, or if there is any site of infection. Okay, this should be investigated or examined. So as I said earlier, medication review should be done. Okay, so drug toxicity accounts for approximately 30% of all cases of delirium. So whatever medication the patient is taking should be evaluated. Okay, and clinicians should be careful not to neglect over-the-counter agents. Okay, for example, the common anti-pain drugs. Okay, this is minor, or this is okay ማለት አይኖርባቸውም clinicians. Okay, they should focus on whatever drug the patient is taking. Okay, so drug prescribed by other physicians or drugs belonging to other household members, these all should be reviewed. So when I come to the clinical instruments used for screening delirium, the best one, even the practical one, is the confusional assessment method tool. Okay, so this is a standardized evidence-based tool that enables especially non-psychiatrically trained clinicians to identify and to recognize delirium quickly and accurately in both clinical as well as research settings. Okay, so there are two versions of this confusional assessment method, both the confusional assessment method and there is the ICU version, CAM ICU version. Okay, they have a high sensitivity, 94 to 100% sensitivity, and specificity of 90 to 95%. Okay, and they have also high inter-rater reliability. Okay, so this confusional assessment method have four features. Okay, so four features. So the first feature is acute onset or fluctuating course. So this feature is usually obtained from a family member or a nurse that is and is shown by a positive response to the following question. Okay, evidence of an acute change in the mental status from the patient's baseline, or did the abnormal behavior fluctuate during the day, that is tend to come and go or increase and decrease in severity. So that is feature one. So the answer can be yes or no. The second feature is inattention. So for this, you can ask this question: did the patient have difficulty focusing attention, for example, being easily distractible or having difficulty keeping track of what was being said? Okay. And the third one is disorganized thinking. So was the patient thinking disorganized or incoherent, such as rambling or irrelevant conversation, unclear or illogical flows of ideas, or unpredictable switching from subject to subject? okay, and the last one is altered level of consciousness. Okay, so this feature is shown by any answer other than alert to the following question. Okay, overall, how would you rate the patient's level of consciousness? Is it alert, normal, or is it vigilant or hyper alert? Is it lethargic, uh, or is it stuporous, or is the patient in coma state? So from this confusional assessment method, in order to diagnose delirium by this tool, it requires the presence of features of 1 and 2. Okay, 1 and 2 should be present in order to diagnose delirium by this tool. Feature 1 and feature 2 are must, but additionally, feature 3 and feature 4 can be present. Okay, it can or it can not. Okay, but having feature 1 and feature 2 are must to diagnose delirium by this tool. So there are also other instruments like intensive care delirium screening checklist. You can read that. Careful attention to the key features of the acute onset, the fluctuating course, altered consciousness, and cognitive decline should readily distinguish delirium from other conditions like that of depression, psychotic illness, or major neurocognitive disorder or dementia. So the rule of thumb here is to assume delirium and to attempt to rule out common medical etiologies. So if you are in confusion whether the patient is in a delirious state or not, the best way is to put delirium as a working diagnosis and to attempt to rule out common medical etiologies. Okay, so these are the common differential diagnoses for delirium. So major neurocognitive disorder or dementia is the first, the top differential diagnosis. But this condition is differentiated from dementia. I mean, from delirium by its chronic course. Okay, chronic decline in mental function that worsens over time. And people with dementia may be disoriented, but their level of consciousness is usually stable. They have usually a stable consciousness. Okay, so in contrast, people with delirium often have fluctuating level of consciousness and alertness. So this is a key feature that differentiates dementia from delirium. The other differential diagnosis is depression. People with depression are typically aware of their surroundings. Their thinking is usually not as disorganized as in delirium. Especially the hypoactive type of delirium is misdiagnosed as depression. Okay. The third one is psychotic disorder. The third differential diagnosis is psychotic disorder. So psychosis is a condition that causes people to lose touch with reality. So there is impairment in reality testing in psychotic disorders in general. So people with psychotic disorders may experience hallucinations or delusions, right? It can these hallucinations or delusions can also happen in patients with delirium. However, unlike delirium, psychosis is not caused by an underlying medical condition. Usually, medical conditions can push patients to develop psychotic symptom, but these genuine psychotic disorders, they do not usually have underlying medical conditions. That's the first one. The other one is the psychotic symptoms that occur in delirium are usually transient or temporary. Okay, so when the underlying condition is treated, so the psychotic symptom will disappear, right? Unlike that of the primary psychotic conditions. The other differential diagnosis is bipolar disorder. Okay, bipolar disorder can cause mood swings that can sometimes resemble the agitation or withdrawal seen in delirium. However, people with bipolar disorder typically experience these mood swings over a longer period of time. Okay, whereas in delirium it is transient or temporary, and they are not usually accompanied by the same level of cognitive impairment seen in delirium. Okay, so their cognitive status is usually intact in patients with bipolar disorder compared with patients with delirium. And the other one is substance intoxication or withdrawal. Okay, intoxication or withdrawal, especially from alcohol, can mimic the symptoms of delirium. So, however, the history of substance use will usually help you to distinguish these conditions from delirium. So, there are also other many differential diagnoses. These are some of the differential diagnoses. Okay, so now we're coming to an important point of this presentation, which is the management of delirium. So, delirium management focuses on four key aspects. So, if possible, the best way is to prevent it. The second one is addressing the underlying cause, and the third one is providing supportive care, and the last one is pharmacologic interventions when absolutely necessary. So I will elaborate each points. So when we say prevention, episodes of delirium can be prevented. How? By identifying hospitalized people at risk of the condition. For example, we should be alert for patients with medical condition with age 65 years and above. Okay, in general, even though we don't have any symptoms of delirium in such groups, so we know that they are vulnerable groups, so we have to follow their conditions cautiously. Okay, so the same is true for patients with a cognitive impairment, for patients with who undergo major surgery. Okay, or for patients having a severe medical conditions. So these are risk groups. So if we monitor these groups regularly, at least we can prevent the symptoms of delirium, or we can identify it early and treat early. Okay, that is the best way. So routine delirium screening is recommended in such vulnerable populations. The second management approach is addressing the underlying cause. Yeah, so this is the primary goal. Okay, so that's why we investigate the medical etiologies in patients with delirium. So this step might involve stopping unnecessary medications. Okay, medications that can cause the symptoms of delirium. It can be correcting electrolyte imbalances. Okay, it can be treating underlying infections, or it can be managing pain. Okay, so addressing the underlying cause is the primary goal in the management of delirium. The third one is providing supportive care. So these are often preferred due to their lowest risk of side effects, okay, and focus on creating a calming environment. So by supportive care, we may mean that reorientation. So we have said that patients with delirium are disoriented to time, place, person, okay, or situations. So we have to regularly reorient the patients where they are. Okay, we may need to introduce ourselves. We may need to tell the patients the time, okay, the place. So this will help them to come back to their previous state of mind. Okay, maintaining sleep hygiene. Okay, encouraging mobilization or movement. Okay, minimizing restraints, especially the physical restraints are known precipitating factors for delirium. So minimizing, or if possible avoiding any kind of physical restraints. Okay, and usually having a familiar caregiver. Okay, so when attendants are changed frequently, this can be a negative factor for patients with delirium. So a constant person, one or two person who are familiar to the patient, should stay with the patient whenever the patient is admitted to a medical ward, or wherever he or she is. And hydration and nutrition. This also are supportive cares for patients with delirium. So we can also use pharmacologic interventions if it is absolutely necessary. So medications may be used in specific cases. Okay, not all delirium cases does not need pharmacologic interventions, because For some of them, if we just treat the underlying cause, the symptoms will just go away, okay? But for some cases, we can use medications like antipsychotics, okay? Preferably atypical antipsychotics at a lower dose, okay? If the aim is to control severe agitation or to control perceptual disturbances like hallucinations. But we need to use the medication at the lowest effective dose for the shortest duration possible, okay? We are not targeting to use these medications for long period of time in patients with delirium because we know that the symptoms are transient and temporary. So we go for the shortest duration possible, right? Benzodiazepines are also used for the specifically for alcohol related delirium, okay, alcohol withdrawal delirium. For other cases, it is not recommended because these benzodiazepine drugs have a tendency to worsen the cognitive symptoms. Okay, so benzodiazepines are only used for delirium related to alcohol withdrawal or to treat alcohol withdrawal seizures. Okay, so finally, this is the treatment algorithm for patients with delirium. So I get this from UpToDate. Okay. So as you can see here, when a patient with delirium comes, we immediately start the two approaches simultaneously. Okay. The supportive measures along with checking the underlying causes. Okay. So a patient with delirium, when a patient with delirium comes, the first thing we do is we try to investigate the underlying cause. So what are the medications the patient taking? We take history deeply. We do physical examination and we send basic laboratory studies. Okay, CBC, glucose level, electrolytes, right? Organ function tests, urine analysis, and so on and so forth. Okay, so along with that, we institute supportive measures. So maintaining hydration, avoiding restraints, mobilizing patients, reducing noise, orienting the patient's reassurance. Okay, we do that. So while we investigate the underlying cause, if there is an offending drug, we discontinue it. If there is a trauma or if there is a focal finding, we might need to send CT scan of the brain. Okay. If there is a focus of infection, we begin antibiotic therapy. Okay. So if there is unexplained fever or nodal rigidity, we might need to perform lumbar puncture. Okay. So if there is no obvious etiology, we might further need to evaluate the patients. Okay, it could be vitamin deficiencies like that of the B12 or folate. It could be thyroid abnormalities. We might need to send the thyroid function test. Okay, we might need to do EEG, MRI. Okay, or toxicity screen. So if the patient improves, yes, that's the outcome we need. If the patient does not improve, we go back and we try to reassess the patient. Okay, so the same is true for the supportive management. So we institute these supportive measures. So if the patient behavior interfere with the care or with the safety, we might need to as discussed earlier, we might need to use medications. Okay, low dose antipsychotic medications, preferably a typical antipsychotic, or if we don't have that, we can use the typical high potent antipsychotic medications. Why high potent? Because the low potent medications like that of the chlorpromazine tend to exacerbate the symptoms of delirium. Okay, they tend to exacerbate the sedation, okay, the drowsiness and so on symptoms. Okay, so that is the treatment, the assessment and management algorithm with delirium. Okay, so thank you for attending. That's all I have for today.
All right, Mr. Henok, thank you very much for the nice presentation. I think our participants also enjoyed it. And on behalf of Blue Hills Ethiopia and all our participants, we Thank Mr. Henok for presenting on the 86 Blue Hills virtual seminar. It was indeed a very nice presentation and clear. We also would love to thank all our participants for attending today's seminar. We hope to get Mr. Henok in future seminars with other topics. And thank you to all participants as well.